Well, this has been a great discussion. We've covered a lot of topics. And I think what I'd like to do is conclude by asking my colleagues what they're most excited about in CLL, what they're most excited about in terms of what was seen this year at ASH 2019, and also what they think might be practice changing that was presented at this meeting. This meeting is where most of the new data gets presented, and occasionally it is practice changing. So maybe we'll start with you, Carolyn, in terms of what you're most excited about that was presented here and what you think might be practice changing.
I think I'm most excited by the longer follow-up for the Murano study. I think in Alberta we already thought that a finite duration of therapy would be good. Again, I've mentioned we're in a setting of a publicly funded healthcare system, so we tend to use a lot of chemoimmunotherapy frontline, which I still think is a good option for many patients. But there was a lack of certainty as to how long those remissions would remain. We have much longer data with ibrutinib. The data with ibrutinib still looks excellent in terms of the longer follow-up, which is always shown at the meetings. But I do think that the Murano, that PFS curve, more than 50% of patients still without progression at the 4-year mark is very impressive, and so I think that's what I'm most excited about from a practice change. So acalabrutinib is going to become available, and I'd really like to see with the ongoing data. I'd like personal experience as well. I've treated only a few patients with the drug, and it does. If it proves to be more tolerable, then it would be excellent to just have a good option for patients, because BTK inhibition is such an important part of the management of CLL. It's nice to get more options and hopefully more tolerable options.
Great. Dr. Ma?
So I think the most exciting thing to me are, one is that the next generation BTK inhibitor that can potentially overcome the known resistance mechanism, the next generation PI3 kinase inhibitor that has a better toxicity profile, and then the CAR T therapy that can overcome potential novel agent resistance. And then in terms of practice changing, I think the novel combination is still a little bit early, but the data looks so great. For example, the ibrutinib plus venetoclax combination. So that question is currently being tested in several ongoing large clinical trials. For example, in the US, the ECOG study for younger patients, the ALIGN study for older patients, having similar designs combining venetoclax ibrutinib plus obinutuzumab with or without venetoclax. So we're looking at triple combination versus the double combination, whether there's any clinical benefit. I think I like the German study design better, the CLL 17 study, which is actually really comparing what we're using as a standard of care targeted therapy design nowadays. So one arm is ibrutinib alone, the second arm is venetoclax plus obinutuzumab, and then the third arm is ibrutinib plus venetoclax. So that's really going to tell us whether the double target therapy combination, how does that compare to the known standard of care therapy?
Great. Stephen?
I think what the ASCEND study, where the addition of obinutuzumab to acalabrutinib, it challenges the paradigm that adding an antibody to a BTK doesn't add anything. So I think that while it might not be ready for clinical application, it's actually a change in the way we think about combining agents. I think now we have many different strategies. I like the CLL 17, where it's comparing them up front. We still have to work out whether it's best to give all these drugs sequentially or concurrently. From some of our colleagues treating with myeloma, they tend to suggest giving all your active agents together may be the way to go. I'm impressed by Murano, and for many patients, I think the point is that most patients with CLL will respond to whatever therapy, and they will have durable disease control with good disease tolerability. So there's only a small number of patients, perhaps those with 17p, that we select for in the trials that really are the problematic ones. So I think overall the story is good, and it's going to be getting harder and harder to show improvements for the smaller number of patients who have difficult disease.
Yeah, I would agree with everything that's been said. I'm most excited about the combinations, the prospect of getting most of our patients into a good, deep MRD negative remission and a treatment-free interval, and we're seeing that now with the newer combinations. I was happy to see the longer-term follow-up with venetoclax-based therapy. I think that makes people think more about the fixed duration concept and will bring that concept forward. I liked to see the Murano update and the CLL 14 update. I would agree with Carolyn in terms of acalabrutinib and also with zanubrutinib, the emerging irreversible inhibitors, next generation irreversible inhibitors coming into the forefront. And I think probably that will be potentially practice changing, where we'll have the option of acala, zanu, and we'll need to figure out how we're going to make that decision and select treatment. The thing that I'm thinking about a lot now is unmet needs for our patients, and they still have risk for infection, they still get second malignancies, and we've seen that even in patients who are getting very deep remissions. So I think that's an area, having an understanding of immune function and the immune system in patients with CLL is a really a big knowledge gap right now, and how we can fix that, because our patients are living longer. We don't want them getting infections, we don't want them dying of infections or dying of second cancers, and we still see a small population of patients getting Richter's transformation. So I think that still is an unmet need, studying and understanding and knowing how to better treat Richter's transformation. But it's been a great meeting, it's been a great year for CLL, I think, and we've made a lot of progress. So thank you all. Thank you on behalf of our panel. We hope that you found this peer exchange a useful and informative activity.